And on behalf of Ajanta Pharma, we welcome all of the experts and all of the delegates for Cardio Master Workshop Edition 2. So today's agenda is on EP and RFA spotters, basics and beyond. Professor Dr. Aditya Kapoor is speaker for today's program. Moderator, Professor Ajay Mahajan and Professor Milind Phadke are moderators for today's meeting. And we have expert panelists as Dr. Yash Lokhandwala and Dr. Vivek Chaturvedi. Postgraduate students, we have today Dr. Sriram from LTMC Mumbai, Dr. Abhik Haldar from SCBMC Cuttack, Dr. Umesh Tripathi from SGPGI Lucknow, and Dr. Sandeep Sharma from SMS Medical College, Jaipur. So Dr. Ajay Mahajan is Professor and Head, Department of Cardiology, GS Medical College and KEM Hospital, Mumbai. And Dr. Milind Phadke is the Additional Professor at Department of Cardiology, LTM Medical College and LTMG Hospital, Sion, Mumbai. Our presenter for today's meeting, Professor Dr. Aditya Kapoor, is Head of Department of Cardiology Department at SGPGIMS Lucknow. And Dr. Yash Lokhandwala is Senior Electrophysiologist at Holy Family Hospital, Mumbai. Dr. Vivek Chaturvedi is a Senior Consultant Electrophysiologist at Gurugram. With this, without taking much time, now I would request our moderator, Professor Milind Phadke, to kindly kickstart the meeting. Dr. Phadke, sir, over to you, please.
Okay, hi, good evening and welcome everybody once again to class program. And this is our final session for this iteration at least. And we have had 6 wonderful sessions up till now. And Dr. Aditya Kapoor was the expert speaker for the first session. Now we have come and now this concluding this present program. And we are very lucky to have Dr. Vivek Chaturvedi and Dr. Yash Lokhandwala. We have had 6 and we must have enjoyed the piece of which has been spread before that. So I don't want to say much now. I'll hand it over to Aditya Kapoor, sir. The topic is very interesting and it is something that often confuses the students. So I'm sure sir is going to start from the basics and take you step by step towards interpreting what is often seen as a big for the students in their examination. So over to you, sir.
Okay, thank you. Am I audible?
Yes, you are audible, sir.
Yes, sir.
Okay, so thank you so much, and it's a great pleasure to have Dr. Yash and Dr. Vivek here. So they are masters, and of course Yash has been a teacher and mentor to so many of us. Dr. Vivek, one of the most balanced and most well-read persons I have come across in recent times. So we are lucky to have them. And actually, Dr. Ajay Mahajan had told me keep it very, very simple. So I think Dr. Yash and Dr. Vivek will have to sort of shoulder this responsibility and keep on discussing the tracing with the students, because it is really, really very basic and there is no high-end EP involved in these tracings. So I'll just are the slides moving? Are the slides moving?
Yes, yes.
So we all know that EP study involves studying the electrical system of the heart. We place multiple catheters inside the heart, get signals, stimulate the heart, and we can study conduction system disorders or tachycardias, map them. So since it's a huge topic, I thought I'll just discuss some basic stimulation techniques and a few words of something about narrow QRS tachycardias, some maneuvers, some very, very basic maneuvers. And at each step, Dr. Yash and Dr. Vivek can ask questions. So this is the first, sort of a slide. These are the catheters A, B, and C. So would any student want to identify what are the 3 catheters which are being, the left is the LAO view and the right is the AP view. So this catheter has 12 o'clock, this catheter here, and this catheter, this one. Again, the corresponding catheters in the AP view. Would anybody want to have a go? Or shall we? Dr. Yash, what is it?
So no, I'm sure the students will identify.
The catheter A is the for the his bundle activation one, and catheter B is for the cavernous sinus decapolar catheter, and the catheter C is at the RV apex.
RV apex. So you are right in the AP view. So this is how it looks like. In the LEO view, his bundle is at around 12 o'clock. CS crosses the spine. That is how we localize. And this is at the RV apex. Dr. Yash or Dr. Vivek, if you want to add anything, because I'll just keep on moving. If you want to interject or add anything special, you can interrupt. Is that okay, sir?
Yeah, just a point that this is the usual catheter position. Do remember that in REO view, probably REO view is a little bit more yielding information for placing the RV apex, because the apex is not seen. Apex is foreshortened in the AP view. And this is the standard way of putting a coronary sinus, although many of us also put it from the below, that is from the IVC and the femoral line.
Absolutely. Absolutely. So this is, as Dr. Vivek rightly said, so we can place it from the femoral vein or from the IVC, from the foot or from the neck. So in the HRA, you get a prominent A wave. In the His bundle, we all get this A wave and the H signal and the V wave, AHV. In the coronary sinus, we get a sharper A and a bluntish V. And of course, in the RV, we get a predominant V signal. So first of all, everybody of you should be familiar with what chamber records what signal. Obviously, atrial channel will record a prominent atrial signal. The ventricle channel will record a prominent ventricle signal. The His bundle, and these are all quadripolar catheters, if you see. So they get you a bipolar recording from the distal two poles and from the proximal two poles. So you get in the coronary sinus, if you put a decapolar catheter, you get 5 pairs of recordings. So this is a prominent A and a sort of a bluntish V. So this is how the A in coronary sinus looks like. And if I get you this tracing, so this is the standard format on an EP tracing. And if you see, the first 3 are the ECG electrodes, lead 1, AVF and V1 are displayed here. And these are the ultimately the channels. So usually if you see over here, CS 9, 10, 7, 8, 5, 6. So 9, 10 is proximal. So this is from proximal to distal. Conventionally, we place it like this in our lab. Of course, it can vary. So CS 1, 2, remember, is the distal pole. So if you see over here in this view over here, CS 1, 2 will be distal and 9, 10 will be proximal, which is the CS os. So just to get back to this, so if somebody shows you this tracing, so this is CS proximal to distal, this is His bundle distal, His bundle proximal. So how do you identify which is the A and which is the V? Again, it's a very basic question. Most of you would be knowing it, but I just want to understand how would you identify the waves, the deflections. Anybody wants to volunteer, or I mean,
corresponding to the ECG, sir, with the QRS that goes, will consider the V and A with the P wave.
Correct. So with the A wave, so again, these are very, very basic semantics. So we'll just take you through them. And this is from the P wave, you can match the A wave of the His bundle, which is of course on the right side. So this is the His bundle A. And these are the coronary sinuses A's. Following, and with the QRS, you can map the V. And this is the coronary sinus V wave. So if you remember, coronary sinus A is a very sharp deflection, because sometimes in a tachycardia, you will get confused which is V, which is A. So go by the QRS, you can identify by the QRS, you can identify the V. And of course, the other signal will be A. And right here is the H signal in the His bundle. Dr. Vivek, Dr. Yash, I'll just keep on going if you want to add something, if I'm missing something or I'm, sort of not.
Yeah, so yes, I think this is absolutely true. Do remember that the conduction velocities are lower in atrium as compared to the ventricle. And that is why the atrial signals, because the impulse takes some time to exit from the sinoatrial node. And then you can see that there is a gradation of timing of the different atrial responses. But as Dr. Aditya said, all the ventricular signals actually kind of line up almost in the same place, because the conduction is quite fast. And that is one very good way when you are having tachycardia to understand which is V and which is A, is that all the ventricular signals will line up almost in the same line.
So I think that's a very, very important and great point which Dr. Vivek has made. So there is a discernible gap between the P wave, surface P wave and the right atrial activity. And then from the right atrium to the coronary sinus, you'll have the obviously intra-atrial conduction time, and most of the V's will line up together. So again, that is how you identify. And cycle length, it is the interval between, we use this word cycle length, many students get confused, between two normal consecutive normal or paced events. Shorter the cycle length, faster is the rate. And a very quick way to calculate rate in beats per minute is 60,000 divided by the cycle length. So if the cycle length, you are doing a procedure and your consultant or whoever is scrubbed with you say cycle length 500 per pace kariye, so it's about a heart rate of 120. A cycle length of say about 600 is a heart rate of 100. So 60,000 divided by cycle length. What is the AH interval? How do you measure?
So from the A wave, which is seen on the in the intracardiac electrocardiogram, generally in his channel we will see the H wave. So the time from the onset of the A wave to the onset of the H wave is the AH interval.
What does it reflect?
It reflects the atrial conduction from and the delay, which like the delay from the atrial to the AV node, and the total delay, AV nodal delay, is made up of two parts, that is AH and HV interval. The AH interval is just the interval which is from the onset till the channel has till it has reached the bundle of His.
Normal value?
Normal value is around 45 milliseconds.
So onset of the atrial signal to the onset of the His signal, and it's around 55 to 125 conduction time through the AV node. We will take Dr. Vivek's and Dr. Yash's opinion on the next tracing which comes up. What is the HV interval, Sriram?
Sir, it is the interval from the H wave to the V wave, which is seen in His channel.
What V wave? So from the His deflection to the onset of the
onset of
in the ECG, right? And
yes,
reflects the conduction time from His to ventricular myocardium around normally 35 to 55 milliseconds. So this is again the tracing standard format, 3-4 ECGs displayed here. These are the CS's A's. This is the His bundle distal. This is the His bundle proximal, right? So this is the cycle length which I was talking about. The AH interval is around 60 and the HV interval is measured around 46 in this patient. Dr. Vivek, any inputs, any guides, any suggestion to the students?
No, I think
Yes.
Sriram made a mistake when he
Yes,
said HV interval, and that's what many people make a mistake. The A to H interval is both are in the His bundle recording, the A in the His bundle recording and the H in the His bundle recording. But the H to V is the H in the His bundle recording to the earliest ventricular activation. Now, is the earliest ventricular activation in normal sinus rhythm? Where is it? Is it in the His bundle recording or is it in the surface ECG? Sriram?
sir, it will be in His bundle recording.
Where is the His bundle? Is it where the myocardium is activated the earliest, the His bundle? Where is the myocardium activated earliest normally in normal sinus rhythm?
Sir, it is at the base of the heart, in the interventricular septum.
Is it? Is it in the interventricular septum? At the base, you mean near the AV node? Is that part of the ventricle activated earliest? That means the impulse as it goes down the bundle of His starts exiting all over the myocardium. That will be a completely disorganized. That means the bundle branches are of no use then. If the electrical impulse signal is exiting from the bundle of His, then what is the bundle branches for then?
Which part will get activated first?
This is very basic second MBBS level question.
Sir, and the tips where the Purkinje fibers, where they go and where they penetrate into the ventricular myocardium at the base of the heart is the
base. What do you mean by base? We have to be very clear in our concepts. What is the base of the heart? base of the heart, or is what? Is the base on which the heart rests. That is near the AV annulus, the base. So you mean near the tricuspid of the mitral annulus, you are talking of the base?
No, sir. Actually, like the wave of depolarization passed from the endocardium to the epicardium.
But
Normally,
where is the earliest breakthrough? Why do you see the first R wave in lead V1? In lead V1, why is there an initial R wave? So where is it breaking through?
sir, at the near the apical part
Anybody
of
else? Any of the other students, please answer. This is a very simple and basic question.
Anybody else?
There, Aditya, a student is there, na? He should answer.
Sir, at the it's at the base of the IVS, sir, and
What do
from
you mean
goes from left to
base?
right.
What is
No, sir,
base of the IVS?
So the part of the membranous septum, sir.
Membranous septum. The membranous septum is where the ventricle starts getting activated.
It goes from left to right, and then, sir.
So the membranous septum. So that means the heart, the ventricle starts getting activated at the membranous septum. See, remember the His bundle is completely an insulated structure. The His bundle and even the bundle branches are insulated. Current cannot leak out from them. Otherwise, the entire heart synchrony is gone. It's like raw fibers, live fibers. We are insulated, no? We have very clearly in your first MBBS, you have learned that the activation first takes place in the distal third of the interventricular septum. The distal third, not the base. Base means at the upper part of the interventricular. It's at the distal third, and the left bundle activates it from left to right. So the between the proximal 2/3 and the distal 1/3, that is where it breaks out on the right side of the interventricular septum, from left to right, and that's why you get an initial R wave in V1. It comes towards V1, and therefore your His bundle catheter is not near over there. His bundle catheter is at the base. So the ventricular activation in the His bundle catheter will always be after the ECG, after the onset of QRS. I don't know if Aditya can drop a vertical line at the onset of QRS here to illustrate that. So the HV interval is from the His bundle signal to the onset of the earliest ventricular activation. And in normal sinus rhythm, the earliest ventricular activation is not in the His bundle region. Even today, if you take home 3-4 basic concepts, please be one of those. This is one of those basic concepts. It cannot be at the base of the heart. In fact, it is closer to the apex than to the base. Okay.
So that's a very important point, that is why we wanted it to be so basic, because it will always be in the surface ECG, right? It has to be in the surface ECG. And what about here? In the absence of pre-excitation, so, normally you will have a HV interval which is discernible or measurable. So if you see, which Dr. Yash was talking about, so if you draw, I think the arrow is a bit off, but you have a negative HV here in a obviously pre-excited sinus rhythm, right?
Just remember one simple ECG sign in left bundle branch block. One of the signs of left bundle branch block is a pseudo septal infarct pattern, because the wave in V1 disappears and it becomes a QS complex. So the left bundle gives you the initial R wave where it penetrates the interventricular septum.
So measure the AH, HV, the cycle length. So these are the basic intervals, but you should always be able to measure the duration of the P wave, the difference between the RR intervals. So measure all these basic intervals and understand and remember where to measure them, right?
Yeah, just one small pointer that when you are measuring AH and HV interval, do remember that the interval is measured from the onset of the sharp point in the atrium, because atrial signal is a far field signal, so it has to be measured from the sharp point, as has been pointed out here, and not from the onset. And the HV interval should be measured from the most proximal His. So typically, if you have a His signal coming on both your proximal and distal bipoles, typically you would measure HV. This is especially important for Brady studies, is that you need to measure it from the most proximal electrode.
So we'll just discuss some features of supraventricular tachycardia, Dr. Vivek. Is that all right? Because we'll just go ahead. So in any SVT, just see the VA relationship, whether each V is being followed by A, right? Measure the VA interval. So we'll see some tracings as we go along. If you have got a very short VA interval, less than 70 milliseconds, we say it's usually a typical AVNRT or a V on A tachycardia. So that is the A right on top of the V signal. See the atrial activation sequence, see the initiation and termination of tachycardia. We'll see a few examples of changes in cycle length with bundle branch block and a few basic maneuvers if you have time. Right. So ventricle pacing because most of us, at least in our place, we start with ventricle pacing to see the retrograde activation sequence. So you do an incremental pacing or you do extra stimulus pacing, assess the VA conduction, whether the VA conduction is via the AV node or by the accessory pathway. If there is no VA conduction, usually an AVRT is unlikely. AV and RT is also perhaps unlikely, but there are a few exceptions to this rule. But by and large, look for basic VA conduction in the baseline. And decremental VA pacing basically means that you pace from the RV at faster rates, that is shorter cycle length.
Last year.
I think
DM DNB students are sponsors.
I think somebody on unmute. Dr. Milind, maybe you need to mute yourself. So extra stimulus testing, you give multiple extra stimulus. First of all, you give a drive chain, which is a fixed cycle length, followed by a premature beat. And then you reduce the coupling interval of the premature beat progressively. So you give a drive chain and you give a extra stimulus, right? So this is, try to make a diagram. So RV pacing, look for VA conduction. So say this is the RV apex and you have the catheter in the RV apex. So look at, is it nodal conduction? That is, it's going through the central His-Purkinje axis or not? So if it is going through the AV node, obviously the first retrograde A wave will be visible in the His bundle and the VA will decrement because that is the property of the AV node. As you reduce the coupling interval, the V to A interval will keep on increasing. If it is extranodal, say it's an accessory pathway on the left side or on the right side, if it's an extranodal conduction, the earliest retrograde A during RV pacing will obviously be in the catheter pole, which is closest to the accessory pathway. If it is a left-sided accessory pathway, left lateral pathway, it will be closest in CS12. If it is a posterior pathway, it will be closest in the CS78 or 3-4. If it is on the right free wall, the retrograde A will be, earliest in the right atrial catheter. And usually the pathway conduction is non-decremental. So that is the way you can distinguish during RV pacing, drive chain and extra stimulus. Where is the earliest A? Whether it's it's usually in a nodal conduction, either it will be in the His bundle or in the proximal CS, that is the CS os. It will decrement. And of course, in accessory pathway, it will be an eccentric VA conduction. So I'll just show you this example, and Dr. Vivek or Dr. Yash, if he is still there, they can take us through. So what chamber is being paced? First of all, identify what chamber is being paced. Is it the atrium or the ventricle?
Sir, it's
See the ECG.
It's the left ventricle and being paced, sir, and LBV type of morphology. So most likely RV pacing.
Why left ventricle? Why left ventricle?
Left
Oh,
ventricle.
sorry, RV being paced, sir, and it's the left.
Why do you say right ventricle?
So it's left bundle type of morphology, sir.
So V1 is negative. Which part of the right ventricle?
What is AVF like? Axis क्या है इसका?
AVF negative.
See, you have lead 1 and you have lead AVF. So what
Apex
is the
of the apex of the right ventricle.
What is the axis roughly? What is the axis? You have lead 1 and you have lead AVF. 1 is 0 degrees, AVF is 90 degrees. So what is the axis?
So,
Is AVF positive or negative?
negative.
अरे AVF देखो ना. AVF कौन सी लीड है? लीड नंबर 1 AVF V1 V6.
Dr. Aditya, can you put your pointer and show them the AVF QRS signal? I think they are probably confused because it's at higher speed.
यार
So
मेरा
AVF is positive.
AVF असल में my pointer वो जो है ना वो अभी जो एक pointer लगाया था, that pointer has got disconnected. चलना बंद हो गया. So
Sir, it appears to be the high septal part of the RV because AVF is positive.
so AVF is positive, no?
See, remember, you can pace anywhere from the ventricle. No, it need not be from RV apex per se. With apex, obviously, inferior leads will be negative. So in this signal, you can clearly see that there are some sharp spikes seen in all the electrograms. That is the stimulation spike. And after stimulation, immediately you're getting a QRS. So you are pacing a ventricular chamber. Is that clear so far?
आ गया mouse. Yeah.
And
Yes,
then
sir.
Dr. Aditya had pointed out to you the atrial signals, which were kind of very sharp in the CS, while the ventricular signals were not so sharp. So now the atrial signals are coming after the ventricular signal. So this is a RV pacing going on. Is that clear?
Yes, sir.
So you see, that's what Vivek sir was trying to point out. So this is a pacing stimulus and it is falling right on the QRS. So this is the drive chain and this is the AVF which sir was trying to point out. So AVF is upright, isn't it? AVF is upright. So this is a drive chain, and how is the VA conduction is looking like? Nodal, or which is the channel? So this is the drive chain, this is the extra stimulus, this is the pacing spike, and this is the V. So which channel shows the earliest A?
Isn't the his only, sir?
Yeah, so it looks like the his channel, right? So if you draw a line from here, so it looks like the V, the A and the his is earliest. And if you see the CSAs, they are lined up like this from proximal to distal, right? And the
Yes, sir.
CS is activated proximally to distally. And if you look at the extra stimulus now, so this is the stimulus, this is the V, and again the his bundle A is the earliest. His bundle A is the earliest. The CSs are activated proximally to distally. So looks like a nodal conduction. And if you measure the VA interval, it is clearly decrementing here. You see the gap over here in the drive chain, and you see the gap over here. So it looks like a nodal decremental retrograde AV nodal conduction, which is decrementing. Dr. Yash, Dr. Vivek, would like to add something? Shall I go ahead? So, and now you look at this. So what is happening here? If somebody shows you, so again, if you see over here now, as Dr. Yash and Dr. Vivek were pointing out, the stimulus is lined up with the QRS. AVF is negative here. So AVF is negative, V1 is negative. So probably you're pacing from the RV apex. And once you have lined up the stimuli, so you see RV pacing, obviously. This is the stimulus, this is the V, and this is the A. So what is happening over here in the extra stimulus? You have a stimulus, you have a V. Do you have a A? Retrograde A hai ya nahi hai?
Not there, sir.
Sorry?
It is not visible, sir. There is
So it
no
is not there. So this has not conducted. So this interval over here becomes the VA ERP, VA effective refractory period, this interval over here. So that is how you can identify. So over here, if I go back to this one, so by this tracing, you can identify nodal versus, so this is a nodal conduction which is decrementing. The last extra stimulus has generated an A. And as you keep on bringing down this interval, bringing down the prematurity of this interval, you will reach a VAERP. And as you come down even further, now you look at this. So again, it's pacing from the right ventricle. If you see, the AVF is upright here, so we are not exactly at the apex. So you see this V, each V is followed by an A. Now over here, if you see, there is no A, but there is no V either. So this pacing stimulus has not even generated a V or a QRS in the ECG. So this is ventricle effective refractory period. So that is how you should distinguish. These are very basic things. So, but again, these are important. So you not only look for the retrograde decrementation, where is it earliest, but you look for VAERP, wherein you will get a pacing spike, a V and no A, and a VERP, where you will get a pacing spike, but no V, either intracardiac or on the surface ECG. So shall I keep on moving, Dr. Yash, Doctor? So you can keep on interrupting wherever.
Yeah, go on.
So now you look at this tracing. So theoretically, I have just drawn, these are the figure over here, and this patient, if you see again the RV pacing. So we are just considering RV pacing now, and I'll keep on repeating these facts because they'll stay in your memory for a longer time. So you identify the chamber being paced, preferably from the surface ECG. So you see there are 3 pacing spikes. Now you try to find out what is the VA conduction like. So drive chain extra stimulus. This is the stimulus, this is the V. Now you clearly see that the A in the CS distal is probably the earliest. So that is why I have marked out with an arrow. And as you remember, Dr. Vivek also pointed out, remember that this is how a A in a CS will look like. So you identify the A, and over here now you see that the his bundle A is clearly late, right? And the CS is activated distal to proximal. And if you see the extra, this is again the drive chain. And if you see again distal to proximal, and even in the last extra stimulus, this is a pacing spike, this is the V, and this is the A and CS distal, followed by the his bundle. So this patient probably during RV pacing, when you are pacing, the CS12 or the CS distal most is the earliest, indicating that the patient could be having a concealed left free wall accessory pathway. Is there any inputs? Shall I?
I just wanted to illustrate to the students that just like you have when you have VA conduction occurring, when you have pace the atrium, you see A, H, and V. Same way, when you pace the ventricle, sometimes you may be lucky to see the V, H, and the A. And in the last, in the extra stimulus, you can see the Aditya is pointing to the his bundle. So this is the retrograde his. So that is, as you're pacing the ventricle also, it is trying to go by the AV node. So it depolarizes the his, but before it can go by the AV node, it is gone by the accessory pathway.
Yeah, just one small thing. So all these tracings, they are like almost like a computer. You only get the information which you are feeding into it. So the A is earliest in 1, 2. But do remember that the pathway could actually be even further up. We are not there, so we haven't got that information. But what we have conclusively succeeded in proving is that there is eccentric, it's called eccentric conduction. And, so there is probably an accessory pathway somewhere on the mitral annulus.
So again, that's a great point. So what sir is trying to say is that if you push the CS catheter even more further, maybe you will get, if you see my pointer over here, so if you push the CS further, you will get even earlier A over here. So this just tells you that this pole over here has the earliest retrograde A, but it could very well be here. So that is why you can push in or push out your CS catheter and try to bracket where the earliest A is.
So to summarize, always in a EP tracing, look first at the ECG. And it may be very fast paper speed. It will be usually fast paper speed. So in the ECG, see which chamber in the if there is any pacing. If there is pacing, is it the QRS coming or the P wave coming? So here we can see there is pacing, there is a QRS, so it's ventricular pace. Then look at lead V1, which ventricle, right ventricle or left ventricle? And then look at limb leads 1 and AVF from the axis. So which part of the ventricle? Is it the apex or the outflow? So look at the surface ECG first to see whether there is pacing, which chamber is being paced, where it is being paced. Then go to the intracardiac and then look where is the V wave and where is the A wave, either in the coronary sinus or in the His bundle. If there is a consistent A wave after each QRS, after each pacing, that means there is a VA conduction. And the last step is the VA conduction AV nodal? So is it concentric and decremental, or is it by an accessory pathway? Means is it eccentric? So this is how you should analyze a EP tracing when there is a ventricular pacing.
So eccentric VA, as sir said. So now, this is another tracing.
Just one thing, Dr. Sorry. But can somebody tell me what does decremental actually mean? Any of the students? This is an important concept. So, yeah. Sriram?
Sir, as and when we give a stimulus, the time for that stimulus to be conducted further, the time keeps on increasing. That is because each and every subsequent, because it has still not completely recovered from the refractory time, so it takes more time to get conducted.
Yes, so with progressively faster or with sudden prematurity of the stimulation, the tissue's conduction velocity will decrease and encroach upon the refractory period. Yes, so that's right.
So with increasing prematurity, the intervals will increase. So this, as we were discussing, so what is happening here? You are pacing if you see these, here I have written S. So you are pacing look at the QRS. So you're probably pacing the ventricle, right? So these are all the V's which are lined up. And as Dr. Yash and Dr. Vivek are repeatedly pointing out, if you are systematic in your approach, you will not miss too many things. So we see there are at least 1, 2, 3, 4, 5 V's. So which is the best channel to look for A's? Which is the best channel? In fact, it's the only channel here. So CS 910. So what is the pattern of VA conduction now? What is it?
So there appears to be dissociation.
Yeah.
There is.
So you're right. Oh, sorry. So there is probably no VA conduction, as Dr. Yash and Dr. Vivek were talking about. So if there is no VA conduction, what is perhaps unlikely? Perhaps out of atrial tachycardia, AVNRT.
AVNRT is unlikely.
Dr. Yash, Dr. Vivek?
Sriram, always remember that atrioventricular reentrant tachycardia by definition means it requires both atrium and ventricle to sustain itself. Rest all of them do not require ventricle as a compulsory part of the circuit. So if you don't get a VA conduction, then there are some exceptions, but for all effective purposes, you have ruled out an atrioventricular reentrant tachycardia.
Okay.
So by and large, a pathway will be unlikely, but sometimes, we can repeat all these maneuvers after giving isoprenaline, because sometimes they are catecholamine sensitive, but by and large, as Dr. Vivek said, probably a pathway is unlikely. Dr. Yash?
Yeah, agreed.
Okay. So this is how a VA dissociation or a no baseline VA conduction would look like. So as we have discussed, identify the chamber being paced from the surface ECG, the site of the chamber being paced, whether it's outflow tract or apex, by looking at the axis. Then you see whether each V is followed by an A. If it is, then you look whether it's nodal or extranodal by finding out where is the retrograde A earliest, his bundle, proximal CS, whether it decrements or not decrements, whether it is eccentric, non-eccentric. So systematic approach. So we'll go to this tracing. So again, chamber being paced, we try to identify from the surface ECG.
Excuse me, sir. So can you please explain that concept? I didn't understand why it is that a channel is unlikely, pathway is unlikely. That
Dr. Yash, he wants
Sorry,
to
what
know,
is?
he wants to know when you have no baseline VA conduction, why does a AVRT become unlikely?
Because if there is a pathway, it will conduct. Na? If there is a pathway, it will show for every time you pace the ventricle, it will show atrial activation because the conduction will go through the accessory pathway. Now, if you are pacing very fast, beyond the refractory period of the pathway, then sometimes you may not see 1:1 conduction, but there will be some conduction. And the second thing is that in AV nodal reentry tachycardia, it's not rare that you may not have VA conduction, but you give isoprenaline and you get the VA conduction. The AV node is quite responsive to isoprenaline. The accessory pathways are hardly responsive to isoprenaline. Not that they are not, but very minimally. So in AVNRT, it is not rare that you don't have VA conduction, you give isoprenaline, you get VA conduction, then you get AVNRT. But accessory pathway, if you don't have VA conduction, there is no pathway only. No? Otherwise, there would be a VA conduction by the pathway.
Okay.
So let me just remind you the typical what we say when we say AVRT. The conduction is like this, that the impulse starts from atrium, goes down the AV node, goes into the accessory pathway from the ventricle back into the atrium, and then down again the AV node again. So that is called the circus movement tachycardia. So for this circus movement tachycardia, both atrium and ventricle are integral part of the circuit. And that is why with a VA block, an AVRT becomes exceedingly unlikely.
Now let's forget intracardiac tracing, but think of a basic concept. What are more common, the manifest accessory pathways, that means WPW, or the concealed accessory pathways, that means normal ECG but still hidden accessory pathway? Which is more common, the WPW or the concealed pathways?
concealed ones are more common.
Okay, so concealed are more common, and why is that? In both a patient with WPW as well as patient with concealed pathway, the accessory pathway is present. So why in one it is not able to conduct atrium to ventricle, but only conducts in one direction, that is ventricle to atrium? See, that is the theory of what is called as the impedance mismatch. That means a larger structure activating a smaller structure is easier than a smaller structure activating a larger structure. Now let's translate that to atrium and ventricle. For an atrial impulse to go through the pathway and excite a much larger ventricular mass is more difficult than an impulse going from a larger ventricular mass to a smaller atrial mass. Therefore, if an accessory pathway is present, let's say the right side or the left side, wherever, let's take a left-sided pathway, it can conduct in both directions theoretically. But conduction from atrium to ventricle is more difficult than conduction from ventricle to atrium. You understand what I'm saying?
Yes.
So
Yes,
in
sir.
WPW also, in WPW, the pathway is conducting from atrium to ventricle as well as from ventricle to atrium. In concealed pathways, it is only capable of conducting from ventricle to atrium. So in sinus rhythm, ECG will be normal. In sinus rhythm, you will not see WPW. That is called a concealed path. Have you understood this concept?
Yes, sir. Thank you, sir.
So we'll take this forward. So we are pacing the ventricle, right? We're pacing the right ventricle. So what is happening here? Do you see any change in the conduction from the first two to the third, fourth, fifth beats? So we'll bring out the animations later, but Shriram, if you want to volunteer, is there any, just identify, is there any change in the conduction?
So the The strength of the signal is suddenly increased from the third and fourth loop.
Sorry?
The magnitude, the amplitude of the impulse appears to have increased in the third and fourth loops.
What signal? The which channel you are talking about?
The CS 5634. There
The
appears to be some.
amplitude has changed. Anything else apart from amplitude has
Sir,
changed,
there is
which is very obvious.
Sir, as the ECG moves forward, sir, there is a more distal activation, and initially there is more proximal ones. You can see
more, or what you instead of more, you should say early.
Early.
So the pattern, the amplitudes have changed, but the more important thing is the pattern has totally changed, isn't it? See the
Yes,
his bundle region. You are talking of the coronary sinus. Look at the his bundle region also, and see after that where is the his bundle gone? Much later. So the pattern has completely changed. So why has the pattern changed, Umesh? Who are the other two students? I thought there were 4 students today who are answering.
We also thought there are 4, but I think बाकी दोनों refractory पढ़े हुए हैं. So why has the pattern changed, sir asked. So you see this now, his bundle A has moved later. CS is from proximal to distal become distal to proximal. So why, what has happened? ये दोनों भी off हो गए. Umesh, Sriram?
Yes, sir.
So what has happened? The conduction has changed from something to something, no?
Sir, that the portion, the distal, the proximal portion have now become refractory. So
ये वाली conduction क्या है? What was this conduction? First to be.
Sir, it has become from concentric to eccentric.
Excellent. Excellent.
Very good. Very good. Very good.
So, you know, that is how visually you can detect. And if you want to be sure, as Dr. Yash said, you map out the his bundle, you see it's early. And as Umesh was saying, proximal to distal changes to distal to proximal. So your words have to be very, you cannot say that more of proximal or less of distal. It has changed. The pattern has changed. So it has changed from nodal to extranodal or from central to eccentric, right? Dr. Vivek, shall we move on?
Yes, please.
Yeah. So that was ventricle pacing. Again, to summarize, as you know, our teachers have also told us, Dr. Yash have educated all of you. Identify the chamber being paced, the site being paced, VA conduction present or not. If VA conduction not present, AV-RT unlikely. If VA conduction present, nodal versus extranodal, decrementing or not, his bundle A earliest or not, and whether it changes from nodal to extranodal, right? So this tells you the conduction has changed. So right. So now we come to atrial pacing. Again, we see the same things, antegrade AV nodal conduction. Like for ventricle conduction, we saw VA-ERP, VE-ERP. So we will keep on pacing the atrium till we get a AV nodal ERP, that is A without a V, or a AERP, that is atrial effective refractory period, that is pacing spike but no A. Look for any AH jump, look for AV nodal echo beats, look for tachycardia induction. So we'll see some tracings, right? So what chamber is being paced? So I'll mark out here. You see the pacing spike here. So it is the pacing spike. Now you clearly see the ventricle is obviously not being paced. You might not be able to see a pacing spike good enough in the surface ECG, but which chamber does the pacing spike align with? Which chamber does the pacing spike align with? So CS34 or CS12 perhaps. So you are pacing from the coronary sinus.
Also, because it's a very fast speed ECG, the P wave gets stretched out, so you may not see a proper P wave. So don't be misguided by not seeing a P wave.
This sharp electrical signal tells you pacing spike, and as sir said, you might not be able to see the P wave because the ECG is at a faster speed. See the channel with which the pacing spike gets aligned. So immediately you picked up, as Sriram said, CS. So this is a drive chain, this is the extra stimulus. So again, if you see, this is the A, this is the H, and this is the V. So again, in the drive chain, this is the A, H, and V. Right. and this is the extra stimulus. So you see a H and V. There is a slight increase in the AH interval, which is a normal property of the AV node. It decrements slightly, as Dr. Vivek was telling us. As you bring the prematurity of the extra stimulus, there is a slight AH delay. And if you see this, A goes to H, V, and there is silence after that, followed by resumption of sinus rhythm, which we have not shown. So this is how you will keep on bringing down the extra stimulus. So what is happening here? Again,
Can you just go back one slide, please? Yes. So
sorry.
One practical thing when you take your these sheets are shown to you for your exit exams. Remember that when we give extra, sometimes the amplitude of the hiss comes down. So you, yes, Dr. It is shown very nicely here. You can see that the triphasic diffraction, the amplitude comes down. Somebody else was saying last time amplitude has come down in somewhere else, but by and large in EP we are more concerned with the timing rather than the amplitude of the signals. But this is something which you should be ready to pick up, because sometimes his signal will get small with extra stimulus.
Yeah, again, great point. So sometimes the amplitudes can change, especially when you are getting more and more premature. So you see over here and see over here. So we'll keep on bringing down the prematurity of the extra stimulus. So again, see now over here, you can clearly see the pacing spikes lined up with the P wave. So, and lined up with the intracardiac on the CS channel. So clearly it's the atrium being paced. So this is the drive chain and extra stimulus, just to repeat it again and again. So if you see AHV, and if you see the last extra stimulus, does it generate a QRS? This last extra stimulus. Sriram? So this is the pacing spike. This is the A. It does not generate a QRS, correct?
Yes, there is no QRS.
So it gets blocked in the AV node. It generates a pacing spike. It gives the A signal. So just like a VA ERP, this is a AV nodal ERP, right? And if we bring it down more further, so if you see over here and just see, so you have a distinct A over here, following the pacing spike. Here you just have the pacing spike. There is no A activity. So this is probably the atrial ERP. Right. So again, this is just for understanding. I mean, these are small points, but whenever you are doing a conventional EP and you are measuring all this, so it's useful to remember what is AV node ERP, what is atrial ERP, what is VA ERP versus what is VE ERP. Can I move on, sir? Yeah. So now see this. We had seen this. I'll just go back a second. So we had seen till here. So the last extra stimulus, A, H, and V, and after that there is quiescence followed by sinus rhythm. So now consider this. So here, if you see again, we are pacing the atrium. The pacing spike is lined up with the CS. So if you see here, this is the A, H, and V. Sriram, can you try and tell us? I mean, just, oh, sorry, I brought it out. So this is a pacing spike. This is the A, and this is the, what else is happening over here? What is this? Has the AH prolonged?
Yes, sir.
So there is a significant AH prolongation. What else is happening? Anything extra is happening after this V, as opposed to the previous tracing. Is this V generating something else as well?
So there is a small hiss which is there in the proximal, hiss proximal.
What is this? What deflection is this? I mean, is this A or a V?
A, because it is seen better in CS.
Excellent. So this V, there's a AH prolongation, and this V comes back and generates an extra A, correct?
Okay.
So what could it be? So this is how a AV nodal echo looks like, and this A is unable to go forward through a AV node because it finds a slow pathway refractory. So this is a AH jump followed by an AV nodal echo, right? I'll just show you one more example, and maybe Dr. Yash and Dr. Vivek can discuss this further. So if you see now, this is another patient. So you see, this is the atrial pacing happening, and the last extra stimulus goes by a long AH, that is through the slow pathway. This is the V. It generates an extra A, and this A comes to this V through a long AH and generates another extra A followed by sinus rhythm. So you have two AV nodal echoes. That is A following right in the middle of the QRS. So two AV nodal echoes. Dr. Yash, Dr. Vivek, maybe you'd like to sort of.
So what you can say is, looking at the surface ECG, we must first be very clear about the pacemaker spike. So the pacemaker spike is seen very well over there, and there's a normal PR interval. Look at the ECG from the pacemaker spike. There's a normal PR interval. And see the next pacemaker spike, and again with the QRS, it's a very long PR interval. So suddenly, before looking at intracardiac, always look at the surface ECG. So there is suddenly a very long PR. So if the PR interval has changed from a normal looking PR to a very long PR, that means it could have changed from going by one route in the AV node to another route in the AV node. So the normal PR will be what we call as the fast pathway, and a longer PR is what we call as the slow pathway. And that you can confirm by looking at the His bundle channel. So in the His bundle channel, what has prolonged is the A to the H. The H to the V has remained the same. The previous H to the V and the next H to the V have remained the same. What has changed is the A to the H. See the A to the H before this? Before this, the A to the H, lower down, yeah, lower,
Yes, sir.
yeah. And then the next A to the H, much, much longer. So usually such a sudden change in the AH will denote a dual AV nodal pathways, And then if you combine that with the fact that after that sudden prolongation in the PR and the AH, you get an extra A within A on V. It's called A on V. That means the A is hidden in the QRS complex. So in the surface ECG, you may not see a P wave. And again, after that, there is a A on V. So slow, fast, slow, fast. And this is what typically happens in a, this is like an aborted AV nodal reentrant tachycardia. If this were to go on and on and on, it will be AV nodal reentry tachycardia. Have you understood that?
Yes, sir.
Okay.
Yeah, so often I find that people get confused in this, that whether this is showing, the CS is showing V or A in the last two beats. The best way to again is compare to the previous. So see the first beat. Look at the size and the morphology of the ventricular. No, sir, the same one. Yeah. Look at the size and the morphology of the ventricular signals in the first beat. Yeah. And now you look at the last two beats of interest. So clearly what you see aligning with the surface QRS is not the V of CS, because the V of CS is very small. We saw that in the first beat. Now we are seeing these sharp, brisk, high amplitude signals. So this is an A, which is falling on V, which Yash sir has already explained to you. And I'm sure all of you know it, but I would still reiterate it that AV nodal reentrant tachycardia, the circuit is housed entirely in the atrium. So there is a reentry movement going on between the slow and the fast pathway, and the ventricle and the atria are getting activated simultaneously. So they are not in series. So for example, in sinus beat or in an atrioventricular tachycardia, where atrium, then AV node, then his, then ventricle, and then back to atrium. So this is the series circuit of a typical any electric signal. In AV nodal reentrant tachycardia, the circuit is housed in the lower atrium, and from that the atrium and the ventricle are getting activated together, so the circuit is parallel, and that is why you see the V and A together at the same time.
So have you understood that? So you will get
Yes.
a V on A because the retrograde activation is very fast. And as sir said, you see the sinus beat. You can clearly see the A is like this. So in hindsight, the A will be, this will be A only. So always, as he said, compare during the baseline and remember that how the A in the CS looks like, how the V in the CS looks like. So by and large, you will never be confused which is A, which is V. And this is how, if you get an after the pacing stimulus, there should be quiescence followed by resumption of sinus rhythm. So if you get something extra, see whether the extra A is lined up right with the QRS, outside the QRS. So that is how you will be able to identify. And as Dr. Yash also said, if this perpetuates, now what has happened is that the last A has not gone forward in the AV node because it finds the slow pathway refractory. So at some point of time, if you see over here, we just continue being more premature. So this is the last pacing spike which was given. Atria is being paced. So you see that there is a duality A, H, long PR. If you see over here, surface ECG shows a long PR. And this V now goes quickly by the fast pathway to the atrium and sets up a V on A or a slow fast AV nodal re-entry tachycardia. And again, if you see this V1, you see this slight notch in this V1, which is not there in the baseline ECG. So this is the retrograde P wave, which is being inscribed right inside the QRS. So this is how a slow fast AVNRT will look like. Initiation with the AH jump or AH prolongation. And if somebody shows you this tracing, this is just a similar previous patient. So you have a narrow QRS tachycardia ongoing. You see that these are the V's from the surface ECG, and the A's are all of the CS. They are all lined. The arrow is a bit off. So the A's are lined inside the QRS. So V on A tachycardia. And normally we usually measure a septal VA of less than 70 or more than 70, but a V on A tachycardia by and large suggesting a AVNRT.
So Aditya, there are two questions in this thing. One is that, is there any relationship between conduction velocity and refractory period? Well, no. The simple answer is no. You can have a very long conduction velocity of a structure and a very short refractory period of that same structure, and you can have vice versa. Very rapid conduction velocity, like an accessory pathway which has a long refractory period. So there is no relation between the two. In fact, it's if you multiply the conduction velocity with the refractory period of a circuit, you get the wavelength, but that's apart. The second question is, the refractory period of the accessory pathway is more than AV node or less than AV node? Again, the answer is it could be either. It could be either. Commonly it is less than the AV node, but it can be either.
And so this is a V on A tachycardia. Dr. Vivek, anything else in this?
Yeah. So can anyone tell me what is the textbook definition of AH jump?
What is the textbook definition of AH jump? It is related to how much prematurity and how much millisecond prolongation in the AH?
10 millisecond decrease in the atrial premature complex, in more than 50 millisecond increase in AH interval.
So yes, so do remember that simply sometimes the AH will keep on getting prolonged as the drivetrain is also there, but that is not typically called as AH jump. It is only the response to the premature, that is A1, A2. So with increasing prematurity, the sudden jump when the prematurity is less by 10 millisecond or 50 at least is called AH jump.
So this is how classical AV and RT would look like. So that is, as Dr. Yash was saying, or I think Dr. Vivek was saying, a V on A tachycardia. So you see the V's in the QRSs of the surface ECG, because you are sure you will not miss the, because if you try to see where is the V here, although you can see the V in the his channel, but a safer and a quicker way to identify the V is by the QRS. And A, as Dr. Vivek sir also told us, by the CS. So this is a V on A tachycardia, more suggestive of an AV and RT. Supposing you have this tachycardia, you have just, your consultant has asked you to start a procedure, you are putting in catheters, right? And a tachycardia gets induced. So good way is just put a catheter in the RA and see what is the V and A relationship. So Umesh or anybody, would you like to tell us? So each V seems to be followed by an A, right? Where is the A? Is it lined up with the QRS or is it outside the QRS?
So the question here is, we should ask a simple question, that is this a typical AV nodal reentry tachycardia? Yes or no? Sriram, Umesh, you all should give the correct answer. Can this be a typical AV nodal reentry tachycardia? Yes or no?
No, sir.
No,
No.
it cannot be. So that point should be clear. The first thing when you see like this, what it cannot be is the commonest SVT, which is typical AV and RT. So that leaves us with what are the possibilities what this could be?
So it could be an atypical AVNRT, or it could be a AVRT.
Or
third thing? और क्या हो सकता है? Atypical AVNRT या AVRT, और third thing क्या हो सकता है?
ATL.
atrial tachycardia. Correct.
So it cannot be a typical AVNRT. It can be either of the three. And in this situation, you need to study the earliest atrial activation. During the tachycardia, you need to put in catheter in the CS, and you need to have multiple catheters to localize where is the earliest retrograde atrial activation. So Dr. Vivek now shows you this tracing. So there is a narrow QRS tachycardia going on, right? Would anybody like to have a go? If you see clearly, as we have seen, so this is the A in the CS, this is the QRS. So it's not a typical AVNRT. Which channel appears to have the earliest retrograde atrial activation? Remember, you can see the CS. You know the CS, the A's are the sharper ones. So CS, which channel appears to have the earliest retrograde atrial activation?
So 1, 2.
Good.
CS1, 2.
So this is, as you know, that's not a typical AVNRT. So you draw a line here. CS12 appears to be early, and if you see the his bundle A, it is clearly out here. Right. So it is the CS12 is the earliest. So perhaps it could be a pathway, or it could be a left atrial tachycardia also. But then Dr. Vivek will do certain maneuvers. We will discuss them if we have time. So this is how you will find out. It's an eccentric VA activation. CS12 appears the earliest, could be a pathway. In this case, again, does anybody want to tell us which channel appears to have the earliest retrograde atrial activation?
CS34.
Good, excellent. So CS34 appears to be early. So again, if it is a pathway, it could be somewhere here in the middle. 1, 2, 3, 4 is somewhere here. Another patient, again tachycardia ongoing. Which channel appears to have the earliest retrograde atrial activation? Remember, Dr. Vivek told us that A in the CS is the sharper signal. So which channel appears to have the earliest retrograde atrial activation?
CS78.
Maybe 710 or 98.
78.
7, 8.
Something like that. So it is close to the CS os, right? Dr. Vivek, shall I keep going? You want to add something? I'll go.
Yes. So the last trace which you showed, sir.
Last. This one?
Yeah. So So this kind of a trace is where the problems arise, and you should always tell if somebody asks you, if they show you this trace, that what is the possible diagnosis. So you should mention all the three possibilities.
All the three possibilities.
So those are atypical AVNRT, and it's a concealed accessory pathway, or it could be an atrial tachycardia from somewhere in the lower part of the RA. What it cannot be, and that is, this is the typical long RP tachycardia. What it cannot be is sinus tachycardia. And why this cannot be a sinus tachycardia? Can someone tell me?
Why it cannot be sinus tachycardia? Great question.
Okay, then why don't you look at lead AVF? In AVF, how does the P wave look like?
It's negative, sir.
Negative.
So in sinus rhythm, AVF cannot be negative, and hence this cannot be superior to inferior activation of the right atrium, and hence it is not sinus tachycardia.
So again, great point. So the point to carry home again is, if you are having an activation like this, it cannot be typical AVNRT. So you try to, when you put in multiple catheters, you will be able to find out whether CS12 is the earliest. Could still very well be a left atrial tachycardia. We can do maneuvers. It could be middle of the CS. So again, you need some mapping, and we'll do maneuvers to find out what type of a tachycardia is, but it's a long RP tachycardia, especially if it's this one. Long RP tachycardia, the differential diagnosis we have been told, atypical AVNRT, decrementally conducting accessory pathway in the retrograde direction, or an atrial tachycardia, right? So as we were discussing, sometimes you have this tachycardia on the left panel, tachycardia on the right panel, narrow QRS tachycardia, and something is being done. So what has been done?
So let us forget whether something is done or not. What are these three beats in the middle, Sriram? What are these three beats?
So they are VP beats, sir.
They are ventricular premature complexes. They look slightly different. So are they coming from different foci, or they could be
So
from the same focus?
They appear to be from the RVOT, sir.
So are all three looking similar? See, lead AVF. Look at lead AVF. Are all
First
three
one-
looking similar?
No, sir. The first two appear to be relatively narrower than the third one.
First two, or only the first?
Only the first one appears to be narrow, and the axis changes.
So why could that be? Now suppose we say that these are all three being paced from the same catheter in the right ventricle. They are all three paced from the catheter in the right ventricle, which is in a very stable position. So why is the first QRS relatively narrow and the other two are wider? Anyone else? Any other student can also answer. Because Sriram is being sporting and he's answering everything, but the others also should please help him. Or you must be knowing someone may be having something to say.
The possibility is close to septum.
So, but the catheter is in the same place.
Catheter has not moved.
You cannot see the pacing spikes because of the surface ECG. Sometimes you may not see. I am saying these are all paced, deliberately created pacing from the same spot. So if the first is close to the septum, then other two, why it should suddenly be? Catheter is not moved. I'm telling you, catheter is very stable.
Then it is a fusion.
It's a fusion beat.
Fusion.
So it is.
Sorry, someone said something. Someone
it's a
said
fusion
something.
beat, sir.
Excellent, excellent. Who said that?
Yagnik, sir.
Yagnik, wonderful. So Yagnik is our student from Holy Family, Aditya. So that's a fusion between he said fusion beat, which is perfect. It is actually, see, it has almost come at the same RR interval as the tachycardia RR interval. So it's a fusion. It's a fusion between the pacing and the intrinsic complex, intrinsic QRS. And the other two, then you give faster pacing. So now they are purely paced complexes. So there are three paced complexes. First one is fusion, two are pure pacing, and they are followed by a pause. And after the pause, you see P wave followed by QRS. So the tachycardia continues basically. Tachycardia continues. So is it that the tachycardia has terminated and restarted, or is it that the tachycardia has continued uninterrupted?
So it seems to have continued uninterrupted because the VPBs do not seem to have reset or terminated the tachycardia. So
But suppose I say that it has terminated, and then you have a sinus complex and tachycardia restarts again after the sinus complex.
So the tachycardia has stopped and restarted, sir, because there is a P wave after there is a sinus.
So
it has terminated with the P wave.
So now we have two possibilities, that the tachycardia has stopped and restarted, or the tachycardia has continued uninterrupted. Now let us take the first option was Sriram, that is the tachycardia has continued uninterrupted. If that was true, Sriram, how would you confirm that?
So from the intracardiac ECG?
No, from this ECG. Unfortunately, there are not very clear-cut ways of confirming that, but you can measure the RR intervals if it has not reset. So Aditya, can you measure three RR intervals, or can you make a line joining three RR intervals, and then can you do from that to the first RR interval, if that line can remain the same? So you can do that sort of measurement and see that has it not made any difference to the tachycardia. If it is exactly equal, while Aditya does that, let's give him some time. So he's drawing a line. One more. Yeah, possibly four. Maybe four RR intervals. Yeah.
1, 2, 3, 4.
No, one more. Yeah, and now can you move that same line? Can you copy and paste it? Is it possible?
No.
Okay, it's not possible.
Unable to do that. Sorry.
Okay, so if this interval is exactly equal to, draw from there to the next. No.
Sorry.
From that to the one after the PVCs. Yeah, perfect. So if these two were exactly equal, then that is one possibility. And in that case, Sriram, what would be the mechanism of tachycardia? If the tachycardia is uninterrupted, what would be the mechanism of tachycardia?
Atrial tachycardia, sir.
Excellent. Then it would be atrial tachycardia, because then you can see the P wave before the QRS complex. And if it was an atrial tachycardia, where in the atrium it would be arising from?
Sir,
high in the atrium or low in the atrium?
High in the atrium. 2, 3 AVF are positive, sir.
Very good. Lead 2 and lead 3 are positive. So it would be high in the atrium. Right atrium or left atrium?
So one
AVL positive, right atrium.
One AVL are positive to right atrium.
One is positive. So if one is negative, it would suggest left atrium. AVL, I'm not sure. We need to look at the precordial leads also. So if AVL is negative and lead V1 is positive, you can definitely say it is left atrium. Here, it's not that. So we can say it's high atrium, probably right atrium, or probably in between the two atria, near the center. Now, so that is the first possibility, that tachycardia has continued uninterrupted. If we take the second possibility, who said the second possibility, that tachycardia is terminated? Who said that?
Yes, sir. So Umesh.
Umesh, why don't you show yourself? This is not Saudi Arabia. You're not in a burqa. Okay. So, good. So Umesh, now we take your possibility. that the tachycardia has terminated and it has restarted. If that is the case, what type of tachycardia would terminate with ventricular premature beats? What type of supraventricular tachycardia would terminate with 3 ventricular premature beats?
Which type of tachycardia is more likely to terminate with a ventricle premature beat?
So, AV.
Actually, any type of supraventricular tachycardia can terminate with 3 ventricular premature beats. Remember, with a single premature beat, if it terminates, which is most likely, if a supraventricular tachycardia terminates with a single ventricular and we have written a paper in the Annals of Non-Invasive Cardiology, you should read that. Single ventricular premature beat terminating SVT. But which is most likely?
AVNRT, sir.
No. What did Dr. Chaturvedi tell you? In which of the 3 SVTs is a ventricle? Is the ventricle essential part of the circuit?
So AVRT.
Correct. The name itself tells you atrioventricular reentry tachycardia. AVNRT is atrioventricular nodal reentry tachycardia. And atrial tachycardia is to separate one. So if a single ventricular premature beat terminates, most likely it is AVRT. And if you see on a Holter, next time on a Holter, if you see a SVT terminating with a single PVC, then from the Holter itself, you can say that most likely this is AVRT. Now, if 2 or 3, especially 3 ventricular premature beats terminate, it can be any tachycardia. Okay. Now, Dr. Tripathi, you have again disappeared. We are discussing your possibility. So now we assume that it can be any of the 3. It has terminated and it has restarted. So then how do you explain how it has restarted? What is the mechanism of tachycardia in your hypothesis?
When you say this is a sinus beat, then how does it restart?
Is there any obvious premature beat with which it has restarted? Is there any obvious PAC or PVC which is restarting it?
No.
No, there is no obvious premature beat. No, it's just so. What are the types of tachycardias that start spontaneously without any premature beats? Which type of atrial tachycardia? Which mechanism? Reentrant mechanism?
Focal.
Focal, but focal reentry or focal automaticity?
Automatic or reentry?
Automatic.
So the ones which start, correct. The ones which start spontaneously are the ones with abnormal automaticity or enhanced automaticity, whatever you want to call it. So looking at this ECG, actually, you cannot tell from the surface ECG for sure whether the VPBs have terminated tachycardia, which has restarted, or it is a tachycardia that has continued. For that, you have to really, to be conclusively sure, you have to look at the intracardiac.
These are the intracardiacs. So if you see the intracardiacs, which Dr. Yash was pointing out, these are the VPBs, and right after that, this is the intracardiac signal, and the tachycardia just continues like this. So if you see, so sir, you would like to discuss this, Tracy?
So here you look at the atrial activation in any of the coronary sinus channels. You can look in CS 910 because there is no pacing spike, so you don't get confused. The pacing spike is seen in all the other intracardiac channels, but it is not seen in CS 910. So it becomes easy to look at CS 910. And if you look at the atrial activation, it looks more or less regular. The atrial activation has continued almost uninterrupted by the PVCs. So if the atrial activation has continued uninterrupted, that means the PVCs have not done anything to it, and the tachycardia, that means there's a short period of AV dissociation. the tachycardia continues. So which type of tachycardia then is most likely over here? Dr. Umesh, Ram, anyone else? Yagnik?
The atrial tachycardia.
So atrial tachycardia. Okay, very good. So most likely this is atrial tachycardia. Now can we go to the surface ECG, the previous slide, yeah, and say that, suppose I say AVNRT. In AVNRT, you can have short period of AV dissociation. From the surface ECG, can you rule out AVNRT? The P comes before the QRS, isn't it?
Yes, sir.
And the P is positive in lead 2. Both these things say it cannot be AVNRT. So go to the next intracardiac. So clearly this is atrial tachycardia. This is atrial tachycardia.
Dr. Yash mentioned a very, very important point that upright P wave and lead 2 does means that it could not be AVNRT. Have you understood why? Because the retrograde P waves in AVNRT, they will be usually negative in the inferior leads, right? If at all they are visible. So this is an upright P wave. So he, as he rightly said over here, if you see, the intracardiac show that there is nothing has happened to the tachycardia, just continues, and there is a short period of dissociation, which establishes the diagnosis as a atrial tachycardia, right?
The other thing which was pointed, Aditya was showing also to you, when you look at atrial channel, look at the regularity, it has not changed, and the activation pattern also has not changed. It has remained the same. Look at the way it is going. Yeah.
Sir, I think we have 6 more minutes. Shall I continue?
Yes, please, sir. Yes, please.
There are a couple of pending questions before you continue.
No, you can.
One is who has correctly answered that what is a jump. He has said that there is a sudden increase of the AH interval by 50 milliseconds when you decrease the pacing duration by 10 milliseconds. So decrease by 10 milliseconds, you get increase by 50. That is the AH jump. This one question is, what is the ventricular echo beat? There is nothing like a ventricular echo. It's a very non-specific term. An echo means an extra complex that has come because of the pacing. So it could be atrial echo. It could be AV nodal echo as we showed. And it could be a ventricle echo. So ventricle echo is when you pace the ventricle and you get an extra beat, usually. So how do you identify on the surface ECG is, the question is really, you're not probably, what we were trying to show is it is not a ventricular echo, it is a AV nodal re-entry echo. And that to identify, if you're asking that, then it's difficult. But if you see a R prime in lead V1, which is absent in sinus rhythm, you make, or a pseudo S in lead 2, which is absent in sinus rhythm, you may think that there could have been an echo. Okay.
Yeah, basically when you say ventricular echo, I thought more of R3 phenomena kind of a thing.
Yeah,
which is a bundle branch re-entry.
Yeah, but I think the question was probably meant as to we were discussing, so that's why I stuck to the AV nodal echo. Yeah.
So I'll just, first of all, we'll discuss these 2-3 things because I think this is important. Dr. Vivek and Dr. Yash can teach the residents more about this. How does the tachycardia terminate? Initiation we'll come to later if we have time, because this is again a very, very important thing. We don't pay attention to that very often. So this is a ECG, a narrow QRS tachycardia. And if you see over here, it terminates and it is followed by sinus rhythm. So does anybody want to have a go? How does it terminate? Because sometimes the mode of termination can tell us what type of tachycardia it is or what type of tachycardia it is not. So does anybody want to go ahead? Terminates with a QRS, it terminates with a P. How does it terminate?
Sir, in this case, it's terminating with a QRS, sir.
With a QRS.
Yes.
So I'll blow this up. So this lead 1 and 2, I'll blow it up. So now, how does it terminate?
No, so now it's terminating with the P waves.
So you see this hump over here. So this hump is not in the sinus beat. So you have to be very careful, as Dr. Yash was also telling us. You see this hump is clearly seen in this lead as well. You see this? So sometimes at narrower speed you are unable to make out, but if you look at it very, very carefully, you will be able to see. Again, if you see this R prime which sir was talking about, you see this?
Yeah, you should blow up V1 and show actually.
Actually, I can't I can't blow up V1 now. So but this because agar usko sir V1 ke liye I'll have to stop sharing, but it is clearly
No, that's fine. That's fine. That's fine. No problem.
But again, one should be very careful. So it terminates with a P. So if it terminates with a P, what type of a tachycardia is ruled out? Out of the three we were talking about, AVNRT, AVRT, atrial tachycardia, which is unlikely.
Yagnik?
Atrial tachycardia. Sir.
Yeah. So that's a good point. Even with adenosine, you should see this. When a tachycardia terminates, if it terminates after a P wave, then its atrial tachycardia becomes extremely unlikely.
So this is the corresponding intracardiac of this patient. So if you see, as we were discussing, this is a sharp A signal in the CS. So it terminates with it.
Yagnik, why shouldn't it terminate with an A?
Why does it make
I didn't hear you.
I said, why shouldn't an atrial tachycardia terminate in an A?
Why does termination with an A rule out an atrial tachycardia?
Anyone else?
You're right that it rules out an atrial tachycardia, but why? Umesh, anybody else? So if it terminates with an A, where exactly is it terminating?
Sir, if it's terminating with the A, that means there's retrograde. No.
It's terminating at the AV nodes.
It's terminating in the
AV node. Sir, that's why it terminates with the P wave. The wave has not conducted.
Yeah, correct. Umesh has said correctly. If it terminates after a P wave, that means it cannot go down the AV node, and that terminates the tachycardia, which means the AV node is a part of the tachycardia circuit. So it's an AV node dependent tachycardia. That's the most precise term. So as we would say, bronze medal answer is it rules out atrial tachycardia. Silver is it terminates in the AV node, and gold medal will be it's a AV node dependent tachycardia. That means you are there. That means you have reached there. You understood all this. So examiner doesn't examiner has to go to the next level there. Okay, good.
So this ECG now, if you see, how does this tachycardia terminate? क्योंकि क्लास में हूँ 10 मिनट क्लास में हूँ 10 मिनट में कर लूँ अरे क्लास में हूँ 10 मिनट में कर लूँ
Why don't you look at the 2-3 AVF leads of the tachycardia?
Blow up, sir.
Very, very clear in the first channel, in lead 2. It is so nicely seen in lead 2. How does it terminate, in the P wave or in the QRS?
QRS.
Yes, the last complex is a QRS. The last complex is a QRS. So it terminates in the QRS complex. So does that help you in the differential diagnosis?
No.
What does it exclude? What does it exclude?
All three are possible.
Okay, that's correct. All three are possible. So it exclude nothing. Atrial tachycardia will terminate in the QRS. AV nodal reentry tachycardia more commonly terminates after P but can terminate in the QRS. AVRT again more commonly terminates after a P but can terminate after a QRS. So it doesn't exclude anything.
So again, mode of termination is very, very important. Sir, how does this tachycardia terminate and what is happening? So again, a narrow QRS tachycardia, and you are given probably an extra stimulus over here, terminates. So what is the diagnosis? You give us the complete diagnosis.
AVRT.
Why?
AVRT. Why?
Good.
Perhaps it's refractory PVC.
Sorry?
AVRT is the correct diagnosis, but
AVRT
why?
is absolutely correct. So give us the, I mean, why is it?
Reason why did you say AVRT?
The VPCs have terminated it. So that was discussed that the ventricular
A single PVC has terminated. The word
Single
single
PVC.
is very important.
And what is happening after the termination? Sinus beat mein.
Short PR delta.
So there is clear-cut pre-excitation as well, no?
Yes, sir.
So there is clear-cut delta here. So that means you are fairly certain that there is a manifest pre-excitation. So obviously this has to be orthodromic AVRT, which is going antegrade through the node, retrograde through the pathway, being terminated by a single VPB. So sometimes after the termination, you have to pay attention to the sinus rhythm ECG also, whether there are.
Suppose I were to say now, that can be the last point before we can wind up. This is really for the platinum medal beyond gold. That I say why people with WPW also can have AV and RT. So why single PVC cannot terminate AV and RT? Can anybody answer that? Cannot nahi, but it's very unlikely that a single PVC will terminate a typical AV and RT. Suppose I say, look at that pseudo S in lead 2. This is a typical AV and RT. So why a single PVC is very unlikely to terminate a typical AV and RT?
Sir, I said typical AV and RT, so please note that.
So because of the refractive period.
Refractive period of what? Of what?
Fast pathway.
Before fast pathway, the PVC has to enter the AV node. That's a hint to you. Has to enter, no? To terminate AV and RT, it has to enter the AV node. A single PVC.
His refractory.
Yes, not the his, but the his and the ventricular myocardium. Usually, it will a single PVC gets blocked before it can reach the AV node, because if AV node circuit also is going on, by the time it encounters a delay up the myocardium and the his bundle, it gets delayed. No, by that time the circuit has already established, so it cannot. But 2 PVCs or 3 PVCs can. Why? We just said 2 or 3 PVCs can, because the first one is called peeling back the refractory period. This is called, so first one peels back the refractory period like onion. Second one peels it more, and the third one can get through. So it shortens. So that is these 2 concepts you remember, something called as peeling back the refractory period. Okay. So I think just these concepts are important. Details are secondary.
I'll stop sharing, sir, here, because I think, yeah.
Yes, from class you can now move to glass.
Yes, that is also very, very important. Peeling back the refractoriness. I think it was a great session, and Dr. Vivek, Dr. Yash, thank you so much, because these basic things are very, very important. And as both our moderators have said, that if you look at it very, very in a very systematic manner, look at the ECG, look at the chambers which need to be seen, and you will get the information which you are seeking for. So hopefully we'll have one more session sometime soon.
Okay.
Yeah.
Good night.
Thank you, everyone. Thank you.
Thank you. Bye.
Now, before you log out, the agenda people need to conclude, sir. Please take 2 minutes.
Okay.
Yeah, thank you, sir. Sir, Dr. Mahajan and Dr. Phadke, with your kind permission, can I post the slide which announces the winner's name, sir? And I would request both of you to kindly announce the winner's name, sir. I'm just posting this, sir.
Dr. Mahajan, sir, please.
See, actually, all PG students had done a very good job, but these 2 people were slightly more vocal. They were answering very frequently. Because of that, both are the winners, and both are equal winners. Dr. Sriram and Dr. Umesh Tripathi. One is from HGPGI Lucknow, and one is from LTMJ Hospital Sion. So congratulations, Dr. Sriram and Dr. Umesh. And other participants also, because they had done very good job there. They have participated very actively during this PG teaching program. Congratulations.
Thank you,
Congratulations, Dr. Sriram and Dr. Umesh Tripathi, and our colleagues, our sales colleague will get in touch with you to hand over the prize personally to both of you.
Thank you.
Great, great. Thank you. Bye.
I request Mr. Sunny to kindly say the vote of thanks, please.
Thanks a lot, Dr. Kamal sir. So very good evening to all the respected doctors. On behalf of Ajanta Pharma, I am Sunny Jaiswal, Marketing Head. Would like to take this opportunity to put formal vote of thanks on record for making today's 8th and final Ajanta Cardio Workshop Season 2 with a grand success. Honestly, I am not able to think of one word to describe all 8 workshops. Those were all exciting, challenging, intriguing, enlightening, and much more. Would like to thank our today's speaker, Professor Dr. Aditya Kapoor sir, for his insightful presentation on EP and RFA spotters. My special congratulations to Dr. Sriram from LTMC Mumbai and Dr. Umesh Tripathi, SGPJ Lucknow, for excellent performance in second edition of Ajanta Cardio Master Workshop and for becoming a prize winners. Would like to acknowledge the contribution of today's eminent and expert panelists, Dr. Yash Lokhandwala sir and Dr. Vivek Chaturvedi. Special thanks to our course directors, Dr. Ajay Mahajan sir and Dr. Milind Phadke sir for all the guidance. Sirs, this program would have been incomplete without your experience and knowledge. Also, thanks to all the DM and DNB PG participants and audience for investing the time in learning from the stalwarts of cardiology. I once again thank to all of you for making this event possible, and we hope that your support for Ajanta Pharma will remain in the future too. With this, we conclude our second edition of Ajanta Cardiology Master Workshop. Thanks to one and all. Good night and wishing all a very happy festive season ahead. Thank you.